This is the second podcast in a two-part series on the basics of pharmacokinetics and pharmacodynamics. This second part will cover primarily pharmacodynamics. The objectives are to define that term and define contact-sensitive half-time and the variables that affect it, understand the basic drug-receptor interaction, and give a drug example for each. We will consider the following terms: efficacy, agonist, partial agonist, antagonist, log-dose response curves, slope, and potency. And finally, given an LD50 and an ED50, define what they mean and know how to calculate a therapeutic index. Recall, in contradistinction to pharmacokinetics, that pharmacodynamics is what the drug does to or in the body, unlike pharmacokinetics mentioned previously, which is what the body does to the drug. So pharmacodynamics considers the responsiveness of the receptors and that interaction of the drug with the receptor. We will briefly consider in a slide later on some of the different types of receptors, usually proteins, embedded in some fashion in the cell membrane, and to see how these effects occur. Contact-sensitive half-time is a term that's used to measure of the concentration of a drug and the time it takes for that concentration to decrease by 50% following a constant infusion. There are several variables and assumptions that need to be made. One, and perhaps the most important, is this necessary decrease in drug concentration following the infusion for recovery. 50% is conventionally used, but we know that patients can vary from this and may require only 20% of the receptors to be uncovered for them to awaken following, for example, a total intravenous anesthetic. Or, alternatively, they may require 80% of the drug to be uncovered from its receptor for recovery from anesthesia. A second variable is the duration of the drug infusion. For many drugs, the longer the total intravenous anesthetic, for example, is given, the longer it will take for them to recover from that infusion. And then thirdly, the contact-sensitive effect site decrement time required for the necessary decrease, and that's shown in the y-axis on this particular slide. And this demonstrates two decay curves of drugs that are stopped. One that stopped with a much higher plasma level, and then that decay of that curve from excessive sedation down through the ideal therapeutic range to finally awakening. And the time that takes is considerably longer than if we stop the drug at a lower plasma level at the top or the peak of, say, its ideal therapeutic range, rather than at the peak of it, rather than the peak at stopping it at the peak of the excessive sedation range. That decay is quicker, and you can see that there's a considerable time, even though a scale's not apparent on this x-axis, there's a considerable difference in the time to awakening. I think it's clear that some of these computer feedback loop pumps will help us know more about our patients and have more input to allow us to more accurately target the ideal therapeutic range for an individual patient, such that the time to awakening will follow a shorter time span rather than this other curve depicted up here. This is a chart out of one of the Stoltings and Miller's anesthesia texts, and it depicts the contact-sensitive half-time of a number of different drugs that are commonly used in anesthesia. For example, a drug like propofol or alfentanil or even sufentanil can be infused for a number of hours, for very long cases in fact, and the time after those infusions are stopped for half the drug to diffuse away from the receptor, and hopefully at that point, assuming 50% diffusion from the receptor will cause awakening, that patient will then awaken from their anesthetic. So those drugs tend to be a bit safer and more predictable in longer infusions and longer TIVA anesthetics. This is different from the drug fentanyl, which we know, at least in the adult, that infusions of 3 to 4 hours and beyond will significantly increase the time for half of that drug to dissociate from its receptor. This slide is another way to depict these. The time is on the y-axis, and the infusion minutes on the x-axis. Each curve represents a different contact-sensitive effect site decrement for that drug. So, for example, if a patient only needed, say, 20% of the fentanyl to dissociate in order for them to awaken following a long infusion, one could infuse fentanyl for 10 hours and still not have a difficult time awakening the patient. I think, for example, in the pediatric population, they may live a little further down in this area, but clearly in adults, when this has been looked at, fentanyl after a 3 or 4 hour infusion may take much longer time for the contact-sensitive half-life to occur. Sufentanil is depicted down here, and we can see that, for example, if you want the receptor site concentration to decrease 50% after an 8-hour infusion, because here's the 50% curve for sufentanil, here's the 8-hour infusion, you would need approximately 45 to 60 minutes for that patient to awaken. And for many of you that have done sufentanil infusions, say for example in neurosurgery or other long cases, you know that that is a pretty reliable estimate of the time that is required for this drug for our patients to awaken following an infusion of this drug. If you needed the receptor site concentration to decrease 60% after 8 hours, the time jumps from 45 minutes up to about 90 minutes following an 8-hour infusion. And that's how these curves are interpreted. Let's consider for a minute the different types of receptors that are commonly encountered. There are entire courses and multiple lectures that can be given in pharmacodynamics. This is just sort of a simple configuration of the types of things that are occurring, with a couple of examples when drugs that we give bind with their receptors to cause an effect. Perhaps the easiest to understand is typically considered a G protein coupled receptor, shown here in the far left. Drugs like opioids combining with, say, mu receptors are an example of this, or this could be a beta adrenergic receptor onto which a drug like isoproterenol could combine. A classic receptor protein plus an ion channel results in this ligand-gated ion channel configuration. And this gives rise to an ability of certain drugs to alter membrane permeability to ions directly by combining to the ligand in the membrane. This therefore allows, in this case, chloride to rush in and affect a change, a response from the drug. Probably 15%, close to a third of CNS receptors and many of the drugs that we give that act centrally work in this fashion. Two examples listed here are benzodiazepines and propofol. Another example of the receptors that we commonly encounter are these voltage-dependent gated ion channels. And in this circumstance, there is a sodium channel, and the gating is probably made possible by the presence of a voltage sensor, which is a collection of charges that move under the influence of the cell membrane electrical field, and that's why this is called sort of a voltage-gated ion channel. We know that a local anesthetic will move to the inside of the membrane and block this ion channel, disrupting the flow of these ions across, in this case, the nerve membrane, and disrupting nerve impulses down that membrane, causing a sensory or motor block. And then finally we have these drugs that oftentimes can traverse the membrane and combine with, say, for example, a second messenger within the cytoplasm and affect a change through cyclic AMP, for example, or these phosphodiesterase inhibitors that are listed here, such as theophylline or milrinone. So those are a quick overview of the different types of receptors of what's happening in a pharmacodynamic fashion to many of the drugs that we give in anesthesia. Let's consider another way that we talk about pharmacodynamics, and that's getting some of the terms that are commonly used when we draw log-dose response curves, which describe the combination of the drug with the receptor and the effect that causes. One of the terms is efficacy, and that's the intrinsic ability of a drug to produce a given clinical effect. These clinical effects, though, can be positive or certainly undesired effects or side effects, physiologic things that we perhaps don't want to see. They are plotted on the y-axis of the log-dose response curve. A full agonist is 1, a neutral antagonist is 0, a partial agonist is something less than 1, but greater than 0. Potency is typically, or is also referred to as affinity in the pharmacology literature, is typically plotted on the x-axis of the log-dose response curve, and that's the quantity of drug that must be administered to produce a desired effect. And then the slope of the dose response curve, that reflects the receptor binding characteristics. Often you can have 2 or 3 drugs or combinations that give a similar slope, and you can look at the if they are in fact parallel, the mechanism of action for those drugs is inferred to be the same, and one can calculate a potency ratio to figure out the relative potency of those drugs. Slopes can also be used to help determine things like thresholds and spare receptors, which are detailed pharmacologic terms that will probably be encountered in other lectures and not appropriate necessarily for this talk. So here is a log dose response curve. Typically for a log dose response curve, the scale on the left is logarithmic, whereas the scale, the x-axis, is linear. And that allows one to get a sigmoid curve with the bottom asymptotically approaching the x-axis and the top also asymptotically approaching the maximal effect. Remember, the y-axis is typically efficacy. Arbitrarily, maximum effect is attributed as 1, as previously mentioned, with no effect 0. Potency or affinity is typically listed on the x-axis, and there's individual variability which alters the slope, listed here. Let's look at a combination of several log dose response curves and think about what they can mean. For example, if B was morphine, a drug that would be more potent than morphine might be fentanyl, and we know that it's 50 to 100 times more potent. A drug that would be less potent, that could reflect curve C on this, would be meperidine or Demerol or pethidine, which we know is around 7 to 10 times or so less potent than morphine. Since naloxone is a pure mu antagonist, pure morphine antagonist, or competitive antagonist, curve C could also be this same dose of morphine here in the presence of naloxone, which would just shift the curve to the right. Another curve that's been hand-drawn in here is this curve down here, which would reflect more of a partial agonist, one that we're more accustomed to, that I know is still, I believe, used in the obstetric literature, is butorphanol or Stadol, which, again, as a partial agonist, at its maximal dose, is going to have an effect less than the maximal effect seen by these other drugs and depicted on these other curves. So partial agonist has a less than full efficacious response, and note that its slope is different, so it's probably acting at different receptors or in a different way than these other curves are here that depict morphine, fentanyl, and meperidine. The median effective dose, let's look at the final couple of slides here as we consider the term therapeutic index and how it's used to describe a drug's response. The median effective dose, or ED50, is the dose of drug needed to produce a given effect in 50% of the population. It's not the dose required to produce 1/2 the maximal effect. So, for example, in strictest sense, since MAC, or minimum alveolar concentration, is that concentration in the alveoli of an inhalation or halogenated agent that provides an effective response, no movement, to half our population, MAC is really a form or type of ED50. Median effective dose is quite a bit different than median lethal dose or toxic dose.
5665, please. Go to James Cobb Security, 5665, please.
And this is a dose of drug that causes death in 50% of the population. The therapeutic index is the ratio of the median lethal dose to the median effective dose. Let's look at that depicted on a curve. In this case, at this higher dose, you have a log dose response curve. From that, you can figure out the number of individuals who respond. So at 50% respond with death at this dose of, in this case, 400 milligrams. And if the drug is one that maybe is a hypnotic used in anesthesia, we have 50% of that same population responding favorably with hypnosis, sedation, unconsciousness at a dose of 100 milligrams. So the therapeutic index in this case is 4. Obviously, in anesthesia and for any drug, we want higher therapeutic indices for safer drugs. And it is amazing, and many of these drugs would probably not be approved today, but drugs like digoxin, even theophylline, have fairly low therapeutic indices, and it's one of the reasons why perhaps they're not used as much as they used to be used, because the number of adverse side effects and toxicity to the patients is, in many patient populations, unacceptably high because of this low therapeutic index. That concludes part 2 of the basics of pharmacokinetic, pharmacodynamic lecture.